Okay, so clearly it's an area that is not often brought up. It's an interesting, and that's very congruent to what we have found in our research. As a matter of fact, we found that there is more and more research around sexual health and different other types of cancer, but not a whole lot of information around sexual health and brain tumors. So, so what we're hoping to share with you today is to share what we've found, to share what we've heard from yourselves and others, to start, and in some cases continue the dialogue, to normalize what you may be experiencing, and to explore coping strategies. So I'm wondering if that's sort of in line with what you might have been thinking in terms of what this presentation might be, and if there's something else that you might want to focus on. I mean, that's sort of what we're going to focus our presentation on, but what we could do is kind of spend more time in one area over another. Is there anybody have any thoughts around what they were hoping to hear from this presentation? And no? Okay, so we'll just go with what we have and see how things unfold.
Feel free to ask questions as we go along.
Yeah. So what we have found is, of course, that there's not a lot of information on brain tumors and sexual health, as I just indicated. And of course, as you guys have confirmed, it's also not common practice for healthcare practitioners to ask about sexual health issues. Brain tumors affect different parts of the body and mind, which of course impacts sexual health. And there is no one-stop shopping. There's no one solution to address this issue. It really needs to be addressed in an individual, person-by-person, couple-by-couple basis. So today we're going to hope to give some idea of some of the normalization around what you may be experiencing, but also to give you a few sort of broad coping strategies, and then suggest that you explore it further with a healthcare practitioner. So brain tumors affect people in very different ways. And according to the World Health Organization, sexual health is defined as the integration of somatic, emotional, intellectual, and social aspects of sexual being in ways that are positively enriching and that enhance personality, communication, and love. So it's a holistic perspective. It's not just about orgasm and intercourse. It's really taking the individual, all elements of who we are. It's a multidimensional construct that has physiological, psychological, relational, social, and spiritual dimensions. And it's an integration of mind, body, and spirit as a vehicle for experiencing and expressing emotions. And sexual health also is influenced by cultural norms, gender identity, and our own roles in our lives. Of course, our developmental stage, so whether we're young and in our 20s or whether we're in our 50s, 60s, 70s, 80s, it's all very different in terms of where we are in terms of our own sexual health. And sexuality includes, of course, not only intercourse, but hugging, kissing, touching, all that intimacy piece that we can share with one another.
All right. In the context of cancer, what we've found is that, of course, sexuality is always important for both partners, right? The person with the tumor and the partner as well. Sexuality or intimacy is a way to come together, and so it's a form of closeness between the couple, and it often makes this whole experience of cancer or having a tumor more manageable. So the research does show that a lot of people, when they stop intercourse, it may also stop in all form of intimacy, so hugging, kissing, holding hands, and that's often something that will bring a sense of losing a part of the relationship, right? Of feeling like it's not the same. And that's one of the reasons why we have started to look more at sexuality, and why our Cancer Care Ontario counterparts have been talking more about doing some research and asking patients and caregivers and family members what's going on with the sexuality piece of associated with the diagnosis of cancer or having a brain tumor. And often it's not that people don't want to be intimate or sexually active, it's some of the symptoms and side effects of the tumor or the treatments themselves can kind of remove some of that ability to be intimate with someone. It's not fun to be intimate when you're nauseous or vomiting or you have pain somewhere. And so you lose a bit of that spontaneity that you may have had before. And there can be some form of also feeling like the partner may not want to instigate sexual or intimacy aspect of things because you don't want to push your partner, and vice versa, right? The partner knows that you may be, or the person with the tumor may think that you're overwhelmed and there's a lot going on, and so they're not initiating as well. And so communication is really important, and we'll talk some more about communication as we go along. So there's been more, again, as I've said, there's been more research being done. It's something that patients and caregivers have been bringing to our attention a lot more than before. And so there's a few more research being done looking at how sexuality and intimacy is being affected with the diagnosis. And so one of the research that was done in 2002, so not that long ago, ranked sexual desire as an issue on a 6/10 scale. So 6 out of 10 people mentioned that the loss of desire was a problem for them with the diagnosis. 41% of people had with the tumor experienced sexual dysfunction and rated it as a problem as well. So as you can see, there's a lot being done, but that's only the tip of the iceberg. So when we look at it that way, yeah, 6 out of 10 or 41%, but how do we talk to people about it? You know, the fact that only 2 of you raised your hand actually means a lot, right? And so that's why I'm teaching the sexual health class with iPod. We're teaching it to nurses, to healthcare staff, and also to doctors. We're talking more to the oncologist about it, and looking to see how we can kind of make it part of the assessments that we do for people that have been diagnosed. So the changes in sexual health can be caused by many things, right? A lot of it can be physical and a lot of it can be emotional as well. So the cancer itself can cause some issues depending on where it's located. The distress that's associated with the diagnosis can also kind of make people pull apart a little bit. The treatments, of course, with chemo, and we'll go through some of the treatments and the side effects, about the nausea, vomiting, feeling very fatigued, that type of thing. The side effects as well. The distress. A lot of people, after they finish their treatment, find that emotionally it's very hard as well, because you're not actively doing something to get rid of the cancer, even though it may completely be gone afterwards. So that fear of recurrence, all of those things can impact. And some of the relationship can be different because of the stress that's been brought on by this diagnosis. So this is something that I've put together. Mark Fitch is an author that's been doing a lot of research on looking at the whole person approach, not necessarily for sexuality, but as a whole person approach for the emotional aspect of things, and also how treatments impact the whole person. But if we look at the sexuality piece of all of this, it affects every sphere of the whole person. Practical and informational dimension. We look at information and communication and the impact that it has on the couple, not just the person with the tumor. On the physical dimension, the changes due to the treatments or the side effects. Spiritual dimension as well, right? Spirituality influences how we understand our sexual health and how we apply it as well. The psychological, emotional dimension, looking at the psychological distress, the emotional distress, all of that can change the way that we interact and are sexually active. How we look at our body with treatments, after surgery, your looks may change, you may look different than you were before, you may look at yourself differently, even though other people may not see it, right? Or your partner may not see it. Social and relational dimension. A lot of people experience changes in their relationship when they get diagnosed with cancer. Some are for the good and some find it a bit more difficult, right? So that can be impacted as well. So it really affects everything, all the spheres in your life.
Okay. So what you may have noticed, so this of course is really dependent on where you are in your trajectory with cancer, whether you're early diagnosis, whether you've gone through treatment, etc. But these are some of the overriding symptoms, things that you might have experienced. So difficulty with concentrating, and you're being easily distracted, difficulty filtering any ambient noise or activity, difficulty in understanding problems, reduced speed in processing information and articulating your message, difficulty finding items in the home. I don't know, my husband does that, but he doesn't have a brain tumor at this point. Anyway.
I do that too.
Yeah. Problems with reading and writing, short-term memory loss, difficulty remembering faces, common people in your lives, losing objects, inability to multitask and problem solve, poor initiation and follow-through, very concrete thinking, may feel restless and experience panic attacks, difficulty controlling emotions. So if some of these things are, you're experiencing some of these things, it can subsequently, of course, cause a person to be quite irritated and agitated and by themselves, right? So then we're going to start into, so how does all of this affect sexual health? So I'm going to talk a little bit about the different parts of the brain and what they do. This is really a condensed piece. There's a whole lot more information about what the different parts of the brain do, but this just gives a bit of an overall summary. So left side of brain function is related to language, communication, sensation, movement, vision, emotions, behavior, and cognition. And so how might that have an impact on sexuality? Well, it might cause some difficulty in expressing affection, in writing or in words. Diminished social ability, feeling that they need to be more isolated. Decreased feeling and sexual desire, affecting ability to be stimulated to arousal or overly sensitive. And then poor vision could cause impotence, poor self-esteem and decreased self-confidence, impulsive behavior, poor decisions and judgments, which can alienate friends and family, and then poor planning, distractible, and memory challenges. And once again, these are things that you might experience. You may not, but you might, depending on of course, where the tumor is located and how the brain's been impacted. And so, right side of brain function relates to motor, sensory, and visual language, perception, cognitive emotions, and behavior. So you might have difficulty expressing emotions, difficulty communicating, resulting in frustration and anger, misinterpretation and miscommunication, which cause friction in a relationship, loss of balance or clumsiness. You may have lost interest in things that connected you as a couple. So, going to movies, listening to music, other activities that you might have enjoyed and might have been an intimate part of your relationship. Your partner may not be so interested in engaging in those things anymore. Arousal decreased, some difficulty with fine motor skills, lack of initiation of sexual activity, and then sometimes role changes where the caregiver is assuming quite a significant amount of activities in the home. And so then consequently that can create quite a burden on the caregiver as well. And then the prefrontal impact, function is related to emotions and behavior. So difficulty relating to others, not easily aroused, aggressive sexual behavior at times, and sometimes inappropriate sexual talk.
The temporal lobe is that part just above the ear on both sides. So what it can do is it can change some of the taste and the smell and the hearing because of where the tumor can be. It can increase risk of seizure activities, so it may be a concern for both partners, depending if that's, although we have talked to a few oncologists, and he said that shouldn't stop anybody from being sexually active. And of course, there's the medication that we'll talk a little bit more about as well, and sometimes being sterile. The occipital lobe is at the back of the head, and it can impact the vision. So for some people, it impacts their self-image, their self-esteem, and can feel a bit clumsier in their activity. The thalamus, it's inside, so it can impact the sensation that people have. So the sensation of depression, anxiety, and for some people it has an impact on pain that's associated with touch. So being touched can cause some pain, and for that reason can decrease arousal and can lead to difficulty with getting aroused to have sexual relationships.
So then the pituitary gland relates to physical activities. So physical abilities. So there might be changes in the body. Example is enlarged breasts. There might be impotence, once again sterility, lowered self-esteem as a result of these changes in physical abilities, and then decreased sexual desire. So the pituitary is quite a small piece, but it certainly can have a fairly significant impact. And then the brain stem itself also affects physical abilities, and so a person might feel a sense of helplessness to self and then subsequently to others. And so we'll talk, Josee will talk a little bit about impacts of cancer treatments.
So chemotherapy, so all the symptoms and side effects of chemotherapy can be different for everybody, depending on the type of chemotherapy you're getting, if it's pill form, all of those. But the common ones are definitely the nausea, vomiting, fatigue, diarrhea. They're the common ones across the variety of chemo. There's lots of medication that can be given to prevent some of those. But some of the other side effects can be erectile dysfunction, decreased libido, and we hear that for a lot of people, the decrease in wanting to initiate sex and feeling the need to have intercourse. Fertility issues and sexual issues, it can reduce sperm count, so if you're trying to get pregnant, that may be an issue as well. And for some people, that's an issue that can create kind of a pulling away from your partner. With radiation, depending on where the radiation is given, you can have fatigue, nausea, diarrhea, loss of libido, again, erectile dysfunction, and chronic fatigue. Surgery. So, I mean, we're going quickly over the side effects of all of these. And your oncologist and the radiation therapist can talk to you more about some of those side effects when you're in treatments. So the surgery can cause significant short or long-term pain. So not everybody experiences pain once they've healed from the surgery, but some people will experience some pain for a longer period of time at the site or other places in the body as well, because it can damage some of the nerves and can innervate some sexual organs as well. For some people, it can create impotence or erectile dysfunction, ejaculatory dysfunction. It can again decrease desire, change in body image as well, and it's not necessarily just related to just related to the surgery itself, but sometimes because of the scarring from the surgery and the body image, that the image that you have of yourself, even though you may not see the scarring, or people around you people around you may not see the scarring very much, you always notice the scars and how it's changed your body, right, and where it is in your head. So for a lot of people, that body image piece is really important. For some people, it changes their identity of who they are and how they will interact with their partner. For women, it can cause vaginal dryness as well. And for some people, it causes a lack of sexual pleasure.
Okay. So then the other things are the steroid treatment and of course, the steroid treatments are to reduce edema. And it's often combined, as you folks all know probably, that it's often can be used alone or in combination with other treatments. And so these are some of the symptoms that one might experience from use of steroid medication. Increased insomnia, facial swelling and flushing, increased appetite with weight gain, mood swings, and personality changes. So, which might certainly impact one's ability to feel desirable, feel aroused, reduce self-esteem, etc. And then anti-seizure medication, some of the ones that are typically used that I've heard about are Dilantin, Tegretol, and Keppra. Those are the three that I'm most familiar with. But some of the impacts of that can, of course, be fatigue, weakness, nausea, and lack of balance and coordination. Oh, spelled wrong, but okay.
So again, there's been a lot of research on how and what the sexual response cycle has been. It's changed quite a bit from when it was first developed by
Johnson and Johnson.
By Johnson and Johnson. One of the model that we use the most at the moment is Basin's revised sexual response cycle. It was initially done for women, but now it's being used for both men and women. And so what it looks like is basically arousal and desire can go back and forth. So we talk a lot about how you may not feel like you want to initiate sex, or you may not feel that it's, there's a lack of desire. But for a lot of people, the arousal can come before or can come after. So there's a saying that, sometimes l'appétit vient en mangeant. That's the French wording, but
c'est quoi?
L'appétit vient en mangeant. So
oh, you feed is it like sort of feeding the
you get hungrier as you start eating, kind of thing. So, and that's kind of how we can look at this, right? For a lot of people, if the desire is not always there, you can feed it slowly. You can look at it differently. And arousal will eventually come. So instead of arousal, it used to be that the arousal would feed the desire and that would be it. But now we see that it can be different. So there's been a lot of research being done on with cancer patients, but also in the general population, to look at how this all happens. And there's not a one-size-fits-all type of thing here, where everybody's a bit different. So we all have a repertoire. If you've been married for a while, you have a repertoire of how you act sexually against each other, with one another, right? And with having the tumor and the treatments, that may have changed. So there's a need there to relook at that, right? Because the repertoire may not work anymore, because you may not want to be the one to initiate the sexual intercourse or being intimate with each other, or you feel like you're not too sure anymore. So there's a need to look at that again and look at another newer repertoire of what you need to do and what you want to do. So again, arousal, desire, and then there's a plateau, and then you reach orgasm. And the resolution is the period where your hormones come back to normal and your breathing comes back to normal, all of those things. So they've also looked at if there is erectile dysfunction, how does this desire arousal work, and not a lot of people know, or not a lot of men, I think, know that you don't need to have an erection to be able to have an orgasm. And so even though it may be difficult to have erections, it is still possible to be intimate with your partner and still have orgasms. But that's not something that's really been talked about a lot and looked at as well. So we're just starting to look at different ways. There's a lot of medication that will look at only the erection piece of things and how we can make this happen, but the medications don't work for everybody. And so sometimes there is a need to look at different ways of functioning. And for women, there's not the erection piece, but it's the dilation, all of those things. And so we need to look at how women respond as well.
And if I can just comment too, your sexual experience may not be, the ultimate goal may not be orgasm, right? So it just really depends on what your experience is, how you're feeling. Oftentimes we know research, as Josee has indicated, research and discussions with patients have indicated that just being close and intimate can really help in reducing some of the symptoms of isolation and just helping in the quality of life and coping. Right?
There's a lot of, when we look at the media and everything, there's a lot of focus being put on the penetration aspect of things. And it's not necessarily for everyone, and not everyone wants that. But you can still have an orgasm without penetration. And so it's important to look at what you want as a couple and what you need as a couple, right? It can be the intimacy, the being close to each other, touching, that type of thing. It doesn't need to go as far as the penetration if that's a problem. If that's what you want and you want to attain eventually, then we can look, there's different ways that we can look at how this can happen. But the ultimate goal does not need to be the penetration. And we're going to talk about a model that we use for people that want to resume sexual activities as well when there's some issues.
So it's important to know when you need help, right? So these are some of the things that you may experience. You might be feeling isolated and feeling not supported. You might be pulling away from your partner and other loved ones. There might be some difficulty communicating. You might be feeling a sense of burnout. There might be some depressive symptoms, isolating yourself, not eating well, not sleeping well. There might be some anxiety or panic attacks. There might be anger, sleep disturbances, which I already mentioned, and the perception that you have no one to talk about your own feelings. So some of the factors that might affect coping is, and the research talks about this, of course, is the nature of your existing relationship. So the relationship prior to the diagnosis of cancer. Your engagement or your sense of spirituality or engagement in religious activities. So when we talk about spirituality, we talk about more a sense of meaning, a sense of purpose, whereas religion tends to be a more secular, focused on a particular religion, organized activity. So the two may exist together or they might be quite separate. Your sense of community, family, and supports from friends. The physical impact of the cancer will also certainly affect coping. And not only the physical impact, but over the long term. Competing demands in our lives and the complicated nature of symptoms that can occur. And then disease progression, of course, can impact coping. And so we want to talk a little bit about some of the coping strategies. So communication we'll talk about a little bit further in a moment. Of course, an essential piece of our experience of intimacy and coping. Intimate activities that do not necessarily lead to intercourse. So going to movies. I remember one couple told me they enjoyed reading to one another. Going out for walks, some simple things like that where you can feel a connection with your partner. Frequent rest during the day to address issues of fatigue. Time away to explore your own interests. So there's the intensity of that relationship. It's good to try to find ways where you can be a part and engage in your own activities of your own interests or be with other people. Self-care. So not only taking care of yourself as the person with the brain tumor, but also as the caregiver, really important. Asking for help. Sensate exercise, we'll talk a little bit more about that in a moment, what that's about. scheduling time together, not only scheduling time apart, but of course scheduling time together and engage in sometimes very simple activities. Visual clues and tools. I remember a couple told me that when they were out, her husband was a person with the brain tumor. He's got quite verbose, and sometimes it was somewhat embarrassing. So they developed this cue that she would hold his hand and sort of she would just add some pressure, squeeze his hand, say, okay, you're getting a little bit out of hand, and that worked for them, right? So whatever, finding little cues like that. Visual cues, also having messages appropriately around the house, not too scattered because that can be confusing. And engaging in simple tasks, not giving a whole list, 1, 2, 3, 4, 5, all these lists, but one task at a time. Limit distractions. So, rather than having the TV on and the radio on, one thing at a time. Engage in appropriate physical activity to increase strength and endurance. So even sometimes things such as simple walks are nice. So going for swims, that kind of thing. So whatever is appropriate for your level of appropriate for your care. Yoga, gentle yoga is also very good. Communication. So open discussion about what you want and need. Sometimes I think we assume we know what our partner needs, but needs change over time. Even in a relationship where there is no diagnosis of cancer, needs change over time. So clearly needs change with the diagnosis. Talk about it. Talk about your expectations. Don't have high expectations. Start really slow, incremental. Repetitive instructions. So sometimes I know that can get frustrating, but in the end, it may be more effective. The use of I statements without blame. You've probably heard about that. I feel this way when. So you're actually being very sort of concrete about what the issue at hand is. It's really trying to express without putting blame on the other individual.
Especially when we get anxious or frustrated or if there's a lot going on, we tend to just use kind of general statements, right, where it can hurt the other person a little bit more. So using I statement, this is how I feel when this happens, instead of you always do this, and it's communication that we should all use with our partners, and it gets harder to do when you're overwhelmed, when there's a lot happening in your life.
And sometimes taking time away is good too, right? Rather than articulating what's on the tip of our tongue, as we all know, sometimes that's not the most effective. Sometimes we need time away before we really express in an effective
it's okay
way.
To leave the room and go think about how you want to say things and come back.
Yeah. So allow yourself to retreat if getting frustrated. Don't have high expectations. Don't judge yourself or your partner. We're so, as human beings, where our tendency is to immediately judge, and sometimes that's not the most effective way to proceed, because our judgments then predict our behavior and what we express. And intercourse may not always be successful, and as we've indicated, intercourse may not necessarily be the ultimate goal.
So Sensate focus is the exercise that I was talking about. So with a diagnosis, often people will kind of stop having intercourse for at least a little bit, because there's surgery, there's treatments, right, and there's the whole trying to come to terms with this diagnosis. And so trying to get back into being intimate can be difficult, because you may feel like you don't know your partner anymore, or not as well as before. The repertoire may not work, right? The signs and signals that you had for each other before may not work anymore. And so it's kind of relearning how to be with each other. And so this exercise is really to start slow, to get to know each other again, with the ultimate goal not necessarily being penetration again, and especially not in those first few stages. So it's an exercise that you should have time kind of put aside for, because it will take time. And it's something that you can do when in a pleasant evening, let's say, or morning, whichever works for you as a couple. So if the best time of the day for you is in the morning, then it's a good time to set aside some time in that morning instead of trying to do and be intimate when you know you're going to be more tired, when you're going to have more symptoms, and where you're going to be feeling rushed. So you can start by doing what you like to do as a couple. So some couples will say, I like to go for a movie because that's relaxing, or nice dinner, and then come home and have that time. So if that works for you, or if you like to cook together, and that's a relaxing and enjoyable time for both of you, then that could be something that you would do. But you need to find what works for you as a couple. So the first stage is really to just learn about your body touch. The ultimate goal is not having intercourse. It's definitely not penetration. So you remove the focus from breast and genitals. It's really just kind of touching and being intimate with each other, talking about what you like now and what you would like. So how you like your partner to touch you, how you would like things to change, or kind of the touching that you prefer. And that's it for that phase. So you don't, with no expectation that you're going to go further along. This is it. And then you leave it at that for that day. The second stage, and you can redo the same exercise a numerous amount of time until you feel comfortable to move on to something else. A lot of people will kind of expect that will still think that there's an expectation for more, and that's really what we try to focus on is, no, there's not. This is the only step, and we go forward when both partners feel more comfortable. The second stage, or the second exercise, is to include touching the genitals and the breasts. So a little bit more sexual touching. The focus is still not on penetration or intercourse. It really is on relearning your body, relearning what you're comfortable with, and talking about what you like, and the physical sensations. So intercourse is off limits again there. And for some people, they feel that this is a kind of frustrating because they want to go further. If you're comfortable with that, you can always, but that's not part of the exercise, and that's not what we talk about with people. It's really taking it one step at a time. And then the third stage can progress to some manual stimulation with no penetration, and then the focus is still on talking about how you're feeling, discussing your how the touching feels for you, and going forward. And then the fourth stage is actual penetration and full intercourse. So that's an exercise that we use for people that want to resume intercourse. Again, the focus is more on intimacy in the beginning than it is on intercourse. And for some people, they decide to stop at these. And for some others, they will continue on to the fourth stage, which is kind of the full intercourse. So where do people go for support? So in our psychosocial oncology program, our social workers are trained in counseling for sexual health issues as well. You can definitely come and talk with us about those issues. We are hoping to start a sexual health education sessions for men and women in the hopefully near future. It's something that we've been talking more about, and we have nurses that would be coming on board as well. So it is something that we've heard more patients talk to us and caregivers talk to us about a lot more, so it's something we're looking into. You can definitely talk with your oncologist about these issues as well, with your family practitioner, nurse practitioner, if you're more comfortable talking about that there, and go for couples counseling if that's something that you want as well, and that you've worked on and you need help with. Really what we want is for you to not keep all of those issues to yourself, but be able to talk to someone, to a healthcare practitioner, about some of the issues that you may be facing and some of the problems, and get help for those things. Because as we've mentioned, it is something that helps with coping with this whole diagnosis as well.